A 55-year-old man with a history of cirrhosis due to chronic hepatitis C presents to the clinic with increasing confusion and drowsiness over the past 2 weeks. His family reports that he has been more forgetful and disoriented, and his sleep-wake cycle has become reversed. His medical history includes multiple episodes of hepatic encephalopathy, for which he has been treated with lactulose. On examination, the patient appears drowsy but arousable. He has asterixis on hand exam and a distended abdomen with a positive fluid wave test. His laboratory results include ammonia level 150 mol/L, normal 15 to 45 mol/L. AST 75 U/L, normal 8 to 48 U/L. ALT 60 U/L, normal 7 to 55 U/L. Serum creatinine 1.3 mg per deciliter, normal 0.6 to 1.2 mg/dl. He is currently taking lactulose but admits to poor adherence. He denies alcohol use and has no signs of gastrointestinal bleeding. Which of the following is the most appropriate next step in management? A. Increase the lactulose dose. B. Add rifaximin to lactulose therapy. C. Discontinue lactulose and start sodium benzoate. D. Perform a transjugular intrahepatic portosystemic shunt, TIPS. E. Start intravenous antibiotics for spontaneous bacterial peritonitis, SBP. Please pause and write your answer in comments. Now let's find the correct answer. Explanation. The correct answer is B. Add rifaximin to lactulose therapy. This patient is presenting with chronic hepatic encephalopathy, a common complication of cirrhosis that leads to neuropsychiatric abnormalities due to elevated ammonia levels. Lactulose is the first-line treatment for hepatic encephalopathy, but when there is poor adherence or suboptimal response, rifaximin, an antibiotic that reduces ammonia-producing gut bacteria, should be added. The combination of lactulose and rifaximin is more effective in reducing recurrent episodes of hepatic encephalopathy. A. Increase the lactulose dose. While increasing the dose of lactulose may help, adding rifaximin has been shown to be more effective in patients with recurrent encephalopathy. C. Discontinue lactulose and start sodium benzoate. Sodium benzoate is not a first-line therapy for hepatic encephalopathy and is not as effective as lactulose and rifaximin. D. Perform a transjugular intrahepatic portosystemic shunt. TIPS can worsen hepatic encephalopathy by increasing blood flow through collateral vessels, bypassing the liver. It is generally reserved for refractory variceal bleeding or ascites. E. Start intravenous antibiotics for spontaneous bacterial peritonitis. SBP should be suspected in patients with ascites and systemic signs of infection or hypotension, neither of which is present in this case. If the patient is taking lactulose but is not yet passing 3 stools per day, the appropriate next step would be to increase the lactulose dose to achieve the desired stool frequency. The target of lactulose therapy in hepatic encephalopathy is typically 2 to 3 soft stools per day to help reduce ammonia absorption in the gut. Thus, in this modified scenario, the correct answer would be A. Increase the lactulose dose. Key takeaway. In patients with chronic hepatic encephalopathy and poor response to lactulose, adding rifaximin is the next appropriate step to reduce ammonia production and prevent recurrent episodes. In hepatic encephalopathy patients who are not passing 2 to 3 stools per day on lactulose, the priority is to increase the lactulose dose to achieve the desired stool frequency for better ammonia clearance. If you loved this video, please like and hit the subscribe button. We will keep uploading new questions on a regular basis.